Good evening, everyone, and welcome to this Prostate Cancer UK webinar, Prostate Cancer and Your Sex Life. I'm Nick Ridgman, and I'm the Head of Health Information and Clinical Support at Prostate Cancer UK. During this webinar, we will be exploring the impact that prostate cancer treatment can have on your sex life. If you've been diagnosed with prostate cancer and are waiting for treatment, or if you're already adjusting to changes to your sex life after treatment, our information and tips will help you navigate your situation. I'm delighted to be joined by a wonderful panel encompassing expertise and lived experience when it comes to prostate cancer and sex life. I'll let them introduce themselves in a moment, but first I wanted just to let you know how this evening will work. Firstly, just to say we're here on a Zoom webinar. This isn't the same as a Zoom meeting, so everyone is only able to see and hear me and the panelists throughout the whole webinar. Your microphone and camera are not connected to the webinar, so you don't need to worry about that. First, we'll hear from our panel. They'll explore a range of perspectives on prostate cancer and sex life, including the side effects of treatment, what to think about before treatment, what happens after treatment, and partners and relationships. As we're going through, if you've got any questions for the panel, please use the Q&A function to submit them. We will have dedicated time for a Q&A section at the end, where we'll aim to get through as many of these as possible. We also had some submitted prior to this evening, so we'll try and cover those as well. Please don't include detailed personal health information in your question, otherwise we won't be able to answer it. We can't give any health advice on individual cases. And we're sorry if we don't get to your question this evening, but our specialist nurses are always there to help in the usual way. So a few final things. You'll notice that when Chris comes to introduce himself, that his camera is switched off. This is not a technical issue. This is just how Chris would prefer to share his story this evening. Please note that everything in the webinar is for general information purposes to help you understand and navigate your situation better. It does not constitute medical advice. And finally, we will be covering the physical and emotional aspects of sexual side effects appropriately but candidly. If you find it difficult to listen at any point, you can of course step away. We hope to circulate a recording of the webinar afterwards so you can catch up in your own time if you prefer. Now I'm going to hand over to the panel to introduce themselves, starting with Sophie.
Hi everyone, I'm Sophie. I am a senior specialist nurse here at Prostate Cancer UK. I've been working here for 6.5 years. Prior to working for the charity, I was a prostate cancer clinical nurse specialist at Addenbrooke's Hospital in Cambridge, looking after men who were undergoing robotic prostatectomies, running nurse-led follow-up clinics where I would help support and treat side effects of incontinence and erectile dysfunction. Working at the charity, we provide support and information to anyone with a prostate problem or prostate cancer. We have multiple ways in which people can contact us for support. We have the phone service, instant web chat service, WhatsApp and social media. Whilst being at the charity, I helped to set up the sexual support service. That's run by nurses who have a specialist interest in helping people who need extra support with their sexual problems post-prostate cancer treatment. We have a form on the website that you can fill in and then we can call you back. And we're going to post that link in the chat for you so that you could use that if at all you would like us to contact you. Thank you.
Thank you, Sophie. And Will.
Thank you, Nick, and hello everyone. Good to see so many hundreds of people here tonight. That's really brilliant. My name is Will Kinnaird. I'm a consultant therapeutic radiographer working at University College London Hospitals in the middle of London. My background is in radiotherapy. So any of you who've had radiotherapy treatment, I was one of those people getting you in the room, getting you on the bed, delivering the treatment. Since then, I've moved into a specialist prostate role, and my job is now a bit more like the doctors. So, I'm seeing patients, talking about the treatment plans, planning their treatment, seeing them in follow-up. So that takes up half my time. And the other half, I carry out research at UCL, the university next door. And my particular focus is on sexual dysfunction, and in particular, how we can improve support for men. And the main things we find time and time again are that sexual dysfunction is really common. It's almost universal among men going through prostate cancer treatment, that this is a really important issue to men, and very often they don't get the care they need. So it's great to see so many of you here tonight, so you can find out a bit more about what you can do to get help.
Thank you, Will. And last but not least, over to Chris, if you could unmute yourself and introduce yourself.
Hi, my name is Chris, age 56, who underwent laparoscopic radical prostatectomy with partial nerve sparing 8 years ago at the age of 48. Sadly, my histology showed very high residual PSA and multiple lymph involvement, making me considered incurable. I've tailored my treatments over the years with oncology inputs, Prostate Cancer UK input, forum input, and was determined to maintain quality of life firstly, rather than pursue an endless cycle of treatments which would counteract this. Presently, I have been on androgen deprivation therapy for a period of 2.5 years, with metastases to spine, ribs, and some distant lymph nodes. So far, my cancer has remained under control with this treatment.
Thank you so much, Chris, and welcome to all of you, and a big thank you for joining us this evening. And I thought I'd just add before we move on, obviously, a lot of the questions that get submitted to the Q&A might kind of be clinically focused, might be for Sophie and Will, but as we go through and Chris kind of shares more of his story, if you have any questions for Chris, he is obviously part of the Q&A as well, so please do think about submitting those. So we're going to start the discussion by looking at some of the basics around the impact that prostate cancer treatment can have on sex life. So Sophie, coming to you first, what are the various treatments for prostate cancer and how can they cause problems with sex life?
Yeah, so we could be here all night talking about the treatments really, because there are many treatments for prostate cancer, and all of them really can affect the ability to get and kind of keep erections, make you no longer produce the semen after you have orgasmed, make you lose sensations of orgasm. But really I'll kind of we're gonna cover kind of a lot of that through this hour that we'll talk about it. I'll concentrate kind of on 3 main treatments really that men do have that affect that do affect a man's sex life. One of the main ones is surgery to remove the prostate, and this has really a real direct impact on erections. This commonly happens due to the damage to the nerves that sit around the prostate. These nerves are really fine structures. They directly impact erectile function because of that fine structure. Even if they're not removed, and sometimes they do have to be removed for surgery, even if they're not removed, or maybe one side has to be removed, they have to be pulled back. And once they're pulled back, that damage can happen, battering and bruising can happen to those nerves. It can then take a good couple of years to really know whether or not you're going to get any kind of natural recovery of your erectile function back after surgery. And you'll also not produce, because that prostate's been removed, and the prostate is what produces semen, and I know Will is going to talk a little bit about that as well. It then also isn't going to you're not going to be producing any semen after the surgery as well. Excuse me. Now, hormone therapy is another treatment that can and obviously this is kind of a bit of a whistle-stop tour of kind of the treatments and the way that they impact a man's body, and that we have lots more information on this on our website, so it really is kind of a bit of a, as I say, a whistle-stop tour of the treatments and the impacts. But hormone therapy is often given before radiotherapy, or for men with advanced prostate cancer as a lifelong treatment, and this can impact in many ways on a man's body. But one of the main ways that it will affect a man's sex life really is a man's libido, so their sex drive. So they might not feel very sexual, they might not get any thoughts and feelings of sex, and that can make it really difficult to get an erection or keep an erection. It also can shrink the man's kind of sex organs, shrinks the penis, can shrink the testicles, and again, making them produce quite little or no semen. Another treatment is radiotherapy as well, that impacts those nerves that sit around the prostate, that again get the blood to flow into the penis to make an erection. And you might not with radiotherapy see an impact in the erectile function straight away. You might see a decline in the ability to either get or keep an erection, normally after a couple of years after radiotherapy, and this can be due to the damage of those nerves and the way that radiotherapy works in damaging those. However, because of having the hormone therapy often first, you can often see a real lap over in the treatments, having a real significant impact in the treatments. I don't know, Will, if you want to come in here and kind of talk a bit more on the impacts of treatments and the way that they impact a man's kind of sex life a bit more.
Yeah, absolutely. So yeah, I think like Sophie was saying, we tend to concentrate on erections. I think both patients, men who are experiencing these things, and us as healthcare professionals, we tend to concentrate on erections, and a lot of erectile dysfunction and sexual dysfunction. They're often words used interchangeably, but actually, like Sophie said, there are this whole range of other physical side effects. So yeah, just as you say, the loss of libido, which might be down to the hormone therapy. But actually, we just carried out some research recently with Prostate Cancer UK, and we found low levels of libido right across all treatment pathways. And in fact, even men on active surveillance, on watchful waiting, who haven't started their treatment yet, we found around 50% of those men were reporting that they were experiencing some sort of sexual dysfunction. So that's a really common one. Also really common, as Sophie touched on, is changes to the penis. So shrinkage, or you can get shape change too, up to about 1 inch. More common after surgery, prostatectomy, but also after radiotherapy and the hormone treatment. And if the blood isn't going into the penis and the oxygen isn't going in there, then you can get fibrosis in the tissue, and sometimes that will be more on one side or the other. So you can start to get bending and shape change as well as the shrinkage. And the dry ejaculation, or the reduction in the ejaculation, there's sometimes a misconception on the public that semen comes from the testicles, when actually only about 5% of what makes up semen ejaculation comes from the testicles. That includes the sperm, but that's only about 5%. The rest, or most of the rest, comes from the prostate itself and the seminal vesicles, which are the little tubes that come off the prostate. So about 95% of the fluid is coming from those. So if we remove these things through surgery, or we treat them with radiation, or we treat them with hormone therapy, then the amount of fluid coming out is very much reduced. It may be gone completely, it may be reduced, or sometimes men can experience a change in the consistency of what comes out. And of course, a knock-on effect of that is, of course, there may well be infertility, which can sometimes be overlooked and not talked about. A lot of presumptions are made. Prostate cancer tends to be a disease of older age, so sometimes presumptions are made about whether men are wishing to father children. Of course, we shouldn't presume anything, because this might be something that's very important, and men can father children into much older. Yeah, see Al Pacino, I see he's just recently had a baby, isn't he? 83. So there can also be changes in sensation. So the touch, the feel of the penis, also changes in orgasm. There may be no orgasm. There may be a change in how that feels when it happens. Of course, bladder problems, leaking, incontinence can be a problem during sex. This might happen all the time. It might happen during arousal or during climax, which we might sometimes call climacturia. So of course, that's going to be an important concern. And probably last physical thing to mention is if you're a man who receives anal sex, then prostate treatments can cause damage to the bowel, damage to the rectum. And if you are receiving anal sex, of course, that rectal damage will be sexual damage. But aside from all those physical side effects, I think there are really important psychological and emotional side effects as well, because all these physical problems have a huge knock-on impact. So when we talk to men, we hear them saying things like, I don't feel like a man anymore. I've lost my sexual confidence. I've lost my self-esteem. I've lost my sense of masculinity. And of course, all those things have a huge impact on relationships. And sometimes these things aren't addressed because we as healthcare professionals, and often you as patients, as men, we tend to concentrate on the physical and particularly the erectile function. But these psychological and these psychosexual issues are really important, and because we don't talk about them, they sometimes come as a surprise, but they have a really profound impact. So we do hear men talking about, regretting having their treatment and how these things have changed their life forever. And men often find it difficult to raise these, it's difficult to raise the physical side effects, let alone the emotional, the psychological side effects with either healthcare professionals or even their partners. So yes, erections are really important, but so are all the other physical side effects, and so are all the emotional and the psychological side effects too.
Thank you, Will. We'll move on now to look at that period between prostate cancer diagnosis and treatment, and why it's important to think about your sex life at this stage. And I'd like to bring in Chris here. Chris, what would you say for men in this situation?
It's really tempting to bury your head in the sand, but you must pick a treatment path despite your very real fears of sexual dysfunction. There is no easy way out of side effects, whichever path you choose, but there is real hope to manage them. It is very important to make it clear to your healthcare team that you want full post-treatment support from them regarding sexual function, including ED clinic appointments, access to all available medications, and really a vacuum pump on prescription because they're expensive.
Thanks, Chris. So, and how about kind of communication with healthcare professionals as well, and kind of how that feeds into, I guess, shared decision making with your healthcare professional?
I think really you just need to be very honest with them from the start that your fears are very, very, very real. And it's really important to you to be able to have access to all of the facilities and medications and stuff to really get yourself back on track, because it is possible. Thank you, Chris.
So it sounds like kind of really clear communication and openness between patients and healthcare professionals is really important at this stage. So Sophie, coming to you, can you tell us a little bit more about that?
Yeah. Thanks, Chris. I think it kind of hit the nail on the head, really, because but I'd say, talking about prostate cancer treatment and the impact on erections and a man's sex life, it really should be the job of the healthcare professionals, really at the start of being diagnosed with prostate cancer. It should be, when men are diagnosed, that they're told what is going to happen, and what impact this could leave a man with, just like Will was saying about, being infertile, not presuming things just because men are in their 80s that they're not having sex, that they're, or that they're single, or, that there's so many presumptions that we could have as healthcare professionals, that it's about not making presumptions, and that every person that's sat in front of you at the beginning of their diagnosis, you're having the same conversations with every man about sex and about their sex life and about what potentially could happen to them. And it's also about then, after treatment, having those discussions about their follow-up and what's happened to them, what their what it's like for them, asking really frank, honest, open questions. Because if we ask those questions about erections, about what their sex life is like, about, you know, the treatments that they want to try, if we ask those questions as healthcare professionals, then it means that men know that it's okay to talk. It's safe for them in that environment to be able to talk. Now, when I started as a specialist nurse, in a clinic, I was 30 years old, and I would literally be sat there in front of men who were in their 60s, in their 70s, and I would be asking them, how's things with your erections? What's things like with sex? What do you want? And they'd look at me and they say, I can't talk to you about it. Like, you're 30, you're a young lady. And I would be like, well, you can. And it would take probably a while for them to build up that rapport with me to be able to then start talking to me. But because they knew every appointment they were coming in to see me, I was asking the same questions, they knew it was safe to start talking to me about it. It is the responsibility of the healthcare professional. But we know there are barriers to this, and I know that Will's going to talk about this a bit later. But we know that might not happen, that there are, that people aren't getting face-to-face appointments anymore, that, there's lots of barriers to this. And therefore, especially us on the sexual support service, we really want to empower men, really to be able to own it, be able to open up and talk then to their healthcare team if they're not the ones doing that. Talk and make them know that it's okay to ask for the right treatments and support about what they're needing, that sex is important, that this is a basic need, that you shouldn't be ashamed of asking for it. We British are quite secretive about sex, and often we're not even talking openly to our partners. Before prostate cancer was even on the cards, it was probably sex probably wasn't even something that you were even talking about together. And then all of a sudden you've got this prostate cancer diagnosis, you're having this whole life change, and now all of a sudden it's something that you need to now talk about. But to be able to get the right treatment and the support that you need, it's now unfortunately something that you must talk about to be able to move forward and to be able to get the right support that you need, unfortunately. So communication is absolutely the key to move forward.
Thank you, Sophie. So if I just come back to you, Chris, briefly for a second there, we've heard about the importance of really open and honest communication with your healthcare professionals. Just what was your experience of that, kind of in between diagnosis and treatment? Did you feel like you benefited from that?
I think basically when dealing with the health professionals direct at urology, they were basically, this is going to affect your erections, but there was no more information from them about how severe it could be, what could be done about it. I was at Southampton, and in some ways they were particularly good, the specialist nurses, in that they did have the full Prostate Cancer UK toolkit pack. So it was basically, here you are, take all this home with you and read this. So at least that did get me completely involved with you, but they didn't seem so keen to get involved.
Thank you, Chris. So Sophie touched on their barriers to communication when it comes to that conversation between patients and healthcare professionals. And Will, I think that's something that you can expand on a little bit.
Yeah, so we, I think, like Sophie said, these are conversations that should happen, but they often don't. So we carried out some research looking at communication between men and healthcare professionals around this area of sexual problems. And we did that separately. And I think the results were quite interesting. So firstly, from the patient's perspective, we found that initially men were actually often quite reluctant to talk about sex, especially at the start of their cancer their cancer journey, their cancer pathway. You've just been diagnosed. You're in this, this whirlwind of emotions. You're thinking about the cancer. You're thinking about the diagnosis, survival. What's my treatment plan? So actually, when someone comes along to you and says, I want to talk to you about sex, actually you might not be interested. This might feel completely inappropriate. And especially if you add into that also for those patients going through radiotherapy, and if they're having hormone therapy, or if they've got advanced disease with hormone therapy, perhaps your sex life is your sex drive is low as well. So this may be the last thing you want to talk about, and that is completely understandable. The difficulty is that actually these side effects and what they might do to you might affect your treatment choice. So if libido is really important to you, you may decide to go for surgery instead of radiotherapy and hormones. Or if penis shrinkage is important to you, you might go for radiotherapy over surgery. So it might affect your treatment choice. Secondly, it's important to think about it earlier, because the earlier you tackle these problems, the better. The quicker you get onto them, the less likely you can do things to stop things getting worse. And then probably thirdly, quite quickly, once you do have a treatment plan, once you're treatment is underway, men quite quickly do want to talk about these things. And certainly within 6 to 12 months, they are thinking, actually, this is something I want to talk about. And sometimes the health professional who asked you 6 months ago has already written you off because they've said, oh, he doesn't want to talk about that. So there can be an initial reluctance to talk about this. I think, of course, we can't get away from it. This is embarrassing. Talking about sex is embarrassing. But what I find is that actually men aren't embarrassed to talk about it. They're embarrassed sometimes to raise it. They often don't want to be the one to initiate the conversation. So men are absolutely happy to talk about this, but they almost want to be given permission. They want to be told, this is something that you can legitimately worry about. People often say men don't talk about their feelings, men don't open up. I think they do, actually. It's just they don't often get given that chance to do so. And so, the research we carried out shows that men really want to talk about this, but they usually don't want to be the one to start the conversation. Which kind of leads on to my last point about men themselves, is that often we found the main barriers that men raise to discussing these things are actually quite practical. I don't know who to ask. I don't know what to ask. I don't know when to ask. I don't know how to ask the questions. And these are all quite, logistical, practical questions. So, my advice would be, yes, these conversations should be initiated by the healthcare professional, but it may be that you want to start this conversation early. Talk to your doctor, talk to your GP, talk to your nurse, talk to whoever is managing your care, and ask for help. So you make sure you get onto these things earlier. And then if we flip over to the other side of the healthcare professionals, I think the barriers are often quite different. And I think it's important that you as patients are aware of some of these things that might be stopping them talking to you. So we surveyed, it was mainly doctors dealing with prostate cancer, and so they're all dealing with prostate cancer, mainly doctors. There are also some consultant radiographers and other things in there, and we asked them about what they thought the barriers were to discussing sex. And again, they raised embarrassment. They are just like us. They feel awkward talking about sex as well. They perhaps shouldn't, but they do. But they also don't want to embarrass the patient. They don't want to embarrass any other partner, a partner who might be there. So sometimes they are reluctant to raise these things. There's often also a lack of knowledge and training. There's not an awful lot of sexual medicine in medical training. This is particularly a problem, I think, in oncology, if you're having radiotherapy and hormone treatment, less so in urology, where I think they're more used to talking about these sort of things. So you may have to push this, and you may actually have to battle a bit to get them to refer you on to the right person who does know how to tackle these things. And then a couple of other things that, again, coming back to the presumptions that are being made, advanced disease is something that came up when we asked doctors about barriers. So if they think, this person's got incurable disease, is this appropriate to talk about sex? Maybe this isn't something I should be talking about. And also, within advanced disease, the cornerstone of treatment is long-term hormone deprivation. So the testosterone is low, so they maybe think you're not interested, and actually dealing with these problems is more challenging with a lack of testosterone and that androgen deprivation. So maybe they don't feel they're less willing to sort of open this can of worms because they may not feel like they have enough answers to give you. Age, I think, can also act as a barrier. Again, we talk about the presumptions. You know, if you're a bit older, that they think this isn't something you're doing. And probably the last thing I'd mention is someone else being in the clinic with you. So I had a consultation just last week where a patient brought along his 2 grandchildren. So obviously having a conversation about sex with 2 grandchildren there is incredibly difficult. So, you know, you add those things together, you're in your 80s, you've got advanced disease, you've got your grandchildren, and you're being managed in oncology. These are lots of barriers that are there. So if you are waiting for the healthcare professional to raise the issue, you need to be aware, because maybe they won't, because they're making assumptions about you. So it may be that you need to be clear with them that it is something you want to talk about, and don't take no for an answer, because this is information you need, you have a right to know. And if you're undergoing a course of treatment, of course, you need to know exactly what you're signing up for and the impact that it's going to have on your sex life.
Thank you, Will. That's great. So we're going to move on now to look at what happens after treatment. So, Sophie, what would you say is the most important thing a man should do after prostate cancer treatment?
Sorry. I think after treatment, I mean, obviously it's going to be different about the, you know, at where you're at, and obviously what treatments you've kind of had. As we just said, kind of talking, it's you know, getting the treatment that you feel that you need, and dependent obviously on what kind of treatment that you've had, will depend on obviously where you're at with what treatments for erectile dysfunction that you will be kind of needing. If we think about kind of needing, if you've had surgery, it might be then that you need to have, and you'd be talking about having some penile rehabilitation. Excuse me. And what kind of your goals might be then for getting an erection, really, for kind of now or the future. So it will be kind of like we've said, of who you need to talk to be able to think about kind of what treatment you were wanting after your treatment. So if it is that you are in after surgery and you're wanting to talk about penile rehabilitation, which you know, I'd hope that that was going to be discussed with you by your surgeon or your specialist nurse. It might be that you're in oncology and you are talking to your oncologist, and in which case you then may well need to be referred to a specialist clinic, a specialist erectile dysfunction clinic. So it's really knowing who it is that you need to talk to. Like Will said, it is finding out really who it is that you need to talk to about treatment for erectile dysfunction. Is trying to work. It's also kind of having in your mind what it is that you want from treatment. As Will said as well, about having working out and not when you're first diagnosed, as Will said, often it isn't that you maybe want to even think about sex. You know, it's the last thing on your mind. I want to cure my cancer. Then it often is maybe your incontinence, or you know, you go into the toilet too frequently. So it might be, you know, more practical things around your treatment and needing to recover from treatment and get better. And it's often erectile function that is a little bit further down the line, that once kind of all those practical things are sorted, that's then when you start to think about erectile function. But when you are then starting to think about that, it is then working out what it is for you that is the right pathway for you. You know, is it that you you know, are wanting to be able to get your erections back straight away? Is it that you're wanting to think of actually just see how nature takes its course, and maybe just have you know, a vacuum pump device just to keep your penile tissue healthy? And we can come on to this treatment in a bit more detail soon. But but yeah, kind of making sure then that you are communicating with the right people, and it can be difficult to know who the people are in your area that you need to talk to about getting the right treatment. And it can be difficult for us to know if you call us on the sexual support service, because across the UK it can be different. You know, you can have people like Will who help to manage erectile dysfunction in some clinics, in some hospitals in the UK. You can have other people, other hospitals, that it will just be straight referral to an erectile dysfunction clinic. So, you know, it might be best to ask your specialist nurse in your, if you've got a specialist nurse, what, you know, who is it that I need to speak to about my treatment for my erectile dysfunction. And it's really important that you steer the conversation about what you want from your treatment.
Thank you, Sophie. That's a really great healthcare professional perspective on it. It'd be really interesting to balance that with the patient perspective. So if I can come back to you, Chris, thinking again about that kind of after treatment, you know, straight after treatment moment or stage, what for you then? What did you find was the most important thing for you?
I just really was terrified about having the surgery, but I was determined afterwards to do everything I could to make things right, to get myself functioning again. I just wanted to say that after 8 years, I can first hand reassure you that a very fulfilling sex life can still be had even soon after prostate cancer treatment. And sometimes it can maybe be even better than before. There are so many treatments at your disposal to help with erectile dysfunction, but I really felt that I had to steer my own recovery and push for progress all the time. As the others have said, the NHS just simply doesn't seem to have the time or the availability to really help you out, and you need to keep yourself educated and just try and push forwards as much as you can.
Thank you, Chris. That's really positive message there about how you kind of took control of your own recovery in a really proactive way. So thank you. Sophie, you touched on penile rehabilitation a few moments ago. I wonder if you can explain just a little bit more about that, please, briefly.
Yeah, sure. It can be a really important part of treatment, really, especially after you've had your prostate removed. That's what research has shown anyway. I'll come on to that a bit more. It's shown that really, if you use tablets, which are called PDE5 inhibitors, which are tablets like tadalafil or sildenafil, which are brand names of Cialis or Viagra, and a vacuum pump device to get blood flow, which helps to get blood flow into your penis. And if you use it on a regular basis, so it's kind of recommended once a day, but what I would always say is really using it for what you find that you can. So using it just as regular as you can use it. So if it's every other day, because once a day just isn't practical in your life, every other day is still going to be better than never using it at all. So just using it on a regular basis, it can help to preserve kind of your natural length and girth of the penis, and also help to get a better chance of getting natural erections back. That there isn't the same research that's been done after kind of hormone therapy and radiotherapy, but we do know that I certainly know, I don't know if Will is able to comment any further, but I know from kind of people that I've looked after before and spoken to on the helpline, that they people that have used PD5s and vacuum pump after having hormone therapy, radiotherapy, have done better and been similar after using kind of and doing a kind of penile rehab sort of program. So that would, and as I say, it kind of mimics what the body would be doing kind of naturally to keep the penis healthy. So you kind of get these erections through the night while you sleep, and that doesn't happen while you've often with treatment. So using that pump on a daily basis, you're getting oxygenated blood into the penis, and you're just helping to maintain that natural, you know, body function, and it does help to keep that natural, kind of flaccid length and girth of the penis as well, which can be really beneficial for long term as well if you're using the pump.
Thank you, Sophie. And just briefly coming back to you, Chris, because I know that you've had some success with the pump. I don't know if you want to talk about a little bit how you've used that kind of day to day.
Yeah, I mean, exactly what Sophie said regarding the vacuum pump. Really, whatever treatment path you choose, you need to make it your best friend. You really do, to avoid loss of size and girth and shape. You are losing so many natural erections you don't even know about after maybe you've had, like in my instance, surgery, and later on for people that have had radiotherapy. I'm 8 years on now, and I still use it 3 times a week at least, just while I'm shaving my face. It's simple, it's easy, and it is a game changer, and it's kept me feeling and looking fine still.
That's great to hear. Thank you, Chris. Will, I'm going to bring you back in. Is everyone's journey the same when they're recovering from treatment, or is it a little bit more complicated than that?
Well, I think there are similarities, and there's some important differences as well. I think the one thing that almost all men will have in common, it's that this does affect everyone. Some men will get bladder side effects, some men will get bowel side effects, but pretty much all men will experience sexual problems. And few men will go back to their pre-treatment level of sexual function. It's unlikely to ever be the same again. So I think in that sense, realistic expectations are crucial, because to some degree, nearly all men are going to have to come to terms with some degree of loss of sexual function. So it's not just about recovery, not just about rehabilitation. It's actually about adapting to that, adapting to reduced levels of function. And that means maybe rethinking what your sex life is going to look like, maybe reinventing what your sex life is going to look like. And I think this is where it becomes different, because what the sex life means something different to everyone. The recovery is going to look different for everyone. So I think it's really important the priority is given not to looking back, thinking about I've got to get back to where I was before treatment, but actually looking forward. And what does re-establishing a sex life mean for you? Is your priority having an orgasm? Is your priority intimacy with your partner? What is important to you, and try to focus on that. So particularly for men who have more severe problems and longer term problems, sex therapy, psychosexual counselling may actually be the most important help that men can get, because it may be that you need to do things differently. And there are lots of advice and lots of tips on how to do that. So, simple things to let men know: you don't need an erection to have an orgasm. You don't need to ejaculate to have an orgasm. You may need more stimulation, to achieve satisfaction. Maybe you'll want to think more about things like oral sex rather than penetrative sex. If you're leaking, if you're having incontinence problems, then maybe think about having sex in the shower. But sex therapists often talk about outer course rather than intercourse, with less of an emphasis on penetration. So lots of things you can do differently. Everyone's sex lives are different, so the solutions are going to be different too. I heard somebody once give an analogy, which I'm thinking of reluctantly in my head, but anyway, talking about when you go out, if you go out for steak and chips, and somebody tells you steak isn't available that day, that doesn't mean you go home. That means you have something else. Are you going to have a starter? Are you going to have a drink? Are you going to have a dessert? Are you going to eat something completely different? Maybe you'll never have steak again, but does that mean you never go out to a restaurant again? So I think it's that things aren't going to be the same, but that's no reason why things can't be different, but just as satisfying. And it's great to hear Chris's experience. He sounds like an absolute model, man who's doing all the right things. And really thinking about what's important to him and how actually you can end up with a better sex life than you had beforehand.
Thank you, Will. So Sophie, I'm just going to come back to you for a specific point around kind of timing of penile rehabilitation versus treatment and how the two can kind of interact with each other. What can you tell us about that?
Sorry. Yeah, I think, with regards to penile rehab treatment, there really isn't a one size fits all with that, and there isn't a what's best. It's what's best for each individual man, because if you are having penile rehab, for some men it might be that they really want to get an erection for intercourse. And so then, we haven't really touched on what other treatments there are, but there are treatments like pellets that you put down the water pipe called Muse. And then there are also injection therapy. And those are treatments that are given directly to the penis that kind of bypass the nerves and are able to get you an erection. Well, I say get you, they're able to try to get you an erection without the nerves working, without you having any libido. They work directly onto the penis. So they take perseverance, they take work, and they don't necessarily work straight away because you start at a low dose and then build yourself up. They are something that if you want to be able to get an erection when you are just starting penile rehab, absolutely, it's something that you can, again, it's discussing with your team, because we hear on the sexual support service that some men will say, oh, I need to go through this whole process of having trying the penile rehab, and then we'd be doing that for a while before I then try to have the cream that goes on the top of the penis, to then try the pellets, to then try the injections, where actually you can be doing penile rehab and injection therapy at the same time. So it really is about what is your goal in all of this, because that really is what's always important in all of this.
Thank you, Sophie. That's fantastic. So, I mean, an awful lot of detail there from all of the panel, and we've heard what a long and complicated journey it can be after treatment. Just to close out this section, Chris, I just want to come to you quickly. What in that long and complicated journey, what are some of the most useful sources of information and support that helps you to navigate that?
Right, sorry. I basically was given the toolkit. I joined the Prostate Cancer UK forum anonymously, really, asked a lot of questions. You always get a load of answers. Someone is always there to help. I read all of the information that's readily available on the Prostate Cancer UK website, and the specialist nurses, excellent, always there. Get advice from them. They're really, really good, really candid advice. Basically, that was it, and a little bit of Dr. Google, but not too much.
Sounds like a healthy balance, Chris. And I know how active you are on the online community and how much you support others there, as well as obviously drawing a lot of support from it yourself. So we're going to move on to look at partners and relationships. Of course, this section won't be relevant to everyone, but for lots of men, concerns with sexual function will relate to the sex life that they enjoy with a partner or a spouse. And I'm going to come back to you, Chris. Can you tell us what it was like for you facing the sexual side effects of prostate cancer alongside your wife?
Well, you know, despite my fears, real fears of the cancer and what the treatment would do to me, my wife was really key in obviously pushing me towards treatment because I was only 48, and reassuring me that all would be good. And it was. We had really open and honest conversations about what was going to happen, my real fears of sexual dysfunction, because I was a sexual man. You may be surprised to hear that at the bottom of many partners' list of expectations is to have a solid erection and ejaculation. Sometimes it's quite the opposite. We found that our natural intimacy increased and our closeness, lots of affection, more foreplay, oral and manual stimulation, and some simple sex toys were all we needed and still need. I think we have an enviable sex life, really, and believe it or not, it's possibly better than it was pre-treatment.
Oh, thank you, Chris. So thinking about communication between partners, you know, it sounds like, Chris, obviously you and your wife really communicated very clearly and openly. Sophie, from your experience and what you've seen working in this field, how important is communication between partners?
It's really important, being able to talk openly with your partner about sex and how you're feeling in general, about kind of your loss, because you know it is a loss, is really important. It's something though that, you know, working on the sexual support service, and when I was working in clinic, I often unfortunately did see that you know, that there was, you know, relationship breakdowns, because it can be really confronting. It can be quite a confusing time. It can be where couples kind of, if you don't pull together, you pull away, because it might be that sex was, as I said before, kind of not something that you even spoke about together. And you know, prior to this, and you know, prior to your prostate cancer diagnosis, and now you've got to start speaking about it, you know, after. And you know, as Will said, it doesn't have to be about intercourse. Actually, it can be quite the opposite, and it's about intimacy. And if you start to lose that intimacy, that can be where relationships then tend to often, you know, dissolve more, because it really is about having and keeping that intimacy and that communication. As Will said, psychosexual counselling should really be something that's available to all men after prostate cancer diagnosis, just to help them through that loss, because it really is a grief that men often go through, through kind of losing erectile function, and kind of changes to their sex life. However, it often isn't something that's available on the NHS, and often is something, unfortunately, that does need to be paid for privately.
Yeah, I mean, just to jump in there, I think, you know, I would echo exactly what Sophie's saying. I think the psychological, psychosexual aspects of this are crucial. And again, like Sophie said, this may actually be the first time you've needed to openly communicate with your partner actually about what you want from your sex lives. And often, I think we find that partners may have very different views on the importance of sex. You know, often when I'll see a couple together in clinic, and I'll ask the man, you know, do you want to talk about sexual dysfunction? Would you like some support? And the partner will sometimes jump in. Doesn't matter. It's not important. We don't do that anymore. And, you know, occasionally the man's eyes will narrow slightly, and, you know, and you realize there's very different views here on how important this is. So it may be that sex is more important to one partner than the other. It may also be that, you know, partners are worrying about each other. So you as a man with prostate cancer are worried about your partner, and you want to please them, satisfy them. You're worried about your relationship, and at the same time, your partner is worried about your survival. So there's a real balance between survival and quality of life. You know, somebody may be saying, no, the priority here is survival. The priority here is getting the treatment. The priority is curing this disease. When actually you may be thinking more about quality of life as well. So this can also throw up differences and things that you haven't addressed before. And it's important to remember that relationships work in very different ways for different people. Problems and issues may actually predate the prostate cancer treatment. Not everybody sits in that square box of, married with 2.4 children and all the rest of it. Some men, some people aren't having sex in their relationships. Some men may not have a single long-term partner, particularly think about gay and bisexual men. They may have a series of partners. Some men may be having relationships outside their marriage, outside their partnership. Some will be single. As Sophie said earlier, sexual dysfunction is important for single men too. Some men will be looking to start new relationships. So actually, there's maybe an awful lot to tackle beyond just the effects of the prostate cancer treatment. But as Chris said, tackling those things and thinking about how you want your sex life to look may mean actually not only you re-establish your sex life, but maybe you can improve your sex life in some ways too.
Thanks, Will. Just before we move on, Sophie, you touched on the importance of kind of psychosexual counselling if men can get it, and of course it's unfortunately not routinely available through the NHS. I don't know if you want to just talk about some of the things we're looking at from the perspective of our sexual support service at the moment.
Yeah, so at Prostate Cancer UK, we have our sexual support service. I mean, that provides a space where men and their partners, and we often we can either just talk to men that have had prostate cancer treatment on their own. We can talk to partners of men, or we do it on loudspeaker, and we speak to man and their partner together. And certainly done that many a times, where it just gives you a space really to talk about your sexual problems, and we can just listen and provide you with support, or we can give you some information just to help guide and empower you to make decisions really about kind of your future sex life, and whether that is to be able to start to come to terms with kind of grieving for your loss, or information on how to kind of get your erections again, or finding new ways to have intimacy, as we've talked about, kind of either with yourself or with a partner. However, we're also looking at ways, we're looking at developing the service to be able to contain a psychosexual counselling element. But unfortunately, the nurse who's doing that is going to start her training in the new year, and that's a year-long training before we're then able to develop the service. So it is coming, but it will take us another good year and a half to probably be able to get there. So yeah, it will be there.
Thank you, Sophie. Yeah, so it's a really exciting development, but one to definitely kind of watch this space as we kind of go on that journey as a service, definitely. Thank you. We left some space here for kind of final summing up thoughts and messages from each of the panel, but actually I think you've all spoken in such depth and so clearly already that I think you've kind of got your main points across, and also we are absolutely bursting at the seams with questions for the Q&A. So I think I'm going to move us straight onto that, if that's okay. Now, as I say, there are lots and lots of them, and I will put my hands up and say that unfortunately we won't even come close to getting through all of them in the next 15 minutes. Specialist nurses are always available, and in looking at a lot of these questions, they will be kind of absolutely in the right zone for the specialist nurses to answer. So if we don't get through them, we will obviously be posting the details of the specialist nurse service in the chat towards the end of the webinar. I'm going to start with a couple of questions that came in beforehand, and then we'll move on to some of the ones that came in this evening. So we've got one around drug access here. So a gentleman wrote in and said, since my prostatectomy, I struggle with ED and use an injection to obtain an erection. There appeared to be 3 choices: Viridal Duo, Cavaject and Invacorp. However, in the area that he lives in, Invacorp is not on the list of prescribable drugs. So he is wondering, is there another way of getting it? So Sophie, I think that one might sit with you.
Yeah, that there is. So I think he also said he was having some pain with the other 2, Cavaject and Viridal, which are the same drug, so they're just different manufacturers. Invicorp, you can, if it's not on your prescribed drugs list, it goes the same with vacuum pumps. So I know some men can't get vacuum pumps on prescription, goes the same with those. You can apply for an individual funding request, and that is something then that you can apply for any drugs or any services that you can't, that aren't on the kind of prescribed funding kind of registers. You can apply for as kind of special funding because of your circumstances. So if you need any, that's called an individual funding request. If you need any kind of more advice, if you want to phone us up tomorrow or drop us a live chat, then please do, and we'll, or an email, we'll be able to kind of drop you the link to it if you wanted to tomorrow, whoever asked that question. But yeah.
Thank you, Sophie. We had a really interesting one come in beforehand from a man who had a radical prostatectomy 5 years ago at the age of 72. He said that at that stage he wasn't planning any more children, but since doing quite a lot of work in the prostate cancer area, particularly supporting other men through support groups and one-to-one support, he does speak to younger men going through a prostate cancer journey. And he says he often gets questions around, you know, can I still have children after surgery or chemo? And is feeling a little bit stuck around how he best advises them. So, yeah, in terms of kind of having those conversations with the younger men about fertility and what they can maybe do proactively, I wonder what the best advice is there. Will, I can see you've unmuted yourself, so it seems like you've got something to say.
So there is a good likelihood that a lot of these treatments could leave you infertile. But as we were talking about earlier, there can often be presumptions made that, you know, prostate cancer is a disease of older age, so men, this is something that's important to men. So that's really important. If having a family is something that's important to you, then you need to talk to your doctor, you need to talk about your clinical team about things like sperm banking. So yeah, that's a really important conversation. We should also point out, of course, you won't necessarily be infertile. So, you know, the flip side of things, if you're presuming you're going to be infertile and you don't want any more family, then that's important to think about too. Because yeah, but while the likelihood is you will probably be made infertile by treatment, it's not necessarily, won't necessarily be the case.
Thank you, Will. We've had a few come in around incontinence and leakage, and I guess one that kind of maybe summarizes some of those questions into one. So somebody this evening has asked, I had radical prostatectomy 2 years ago. Urinary incontinence and leakage is a major problem with sexual function and with my partner. How can this be better controlled? So Sophie or Will, I don't know if you want to go for that one.
Yeah, I mean, we could probably both answer it. It is really difficult, and you know, people will feel quite dirty and quite like they don't want to have or have any intimacy or sex if they are leaking urine. No, showers are a good place to be intimate if you are leaking, because obviously it just gets washed away. Depends how much leakage, because obviously you could put a few towels down and you know, on the bed and have intimacy that way. You can wear a condom if that is again able to, if you are having erections and you're, you know, able to wear a condom. One thing I would always say is obviously, you know, urine is a bodily fluid. It's just having to get over that fact that it's urine, which can be really quite difficult, that it is urine, but trying to kind of change that mindset of it being dirty. It's not, it's a, you know, it's clean, it's sterile. You know, trying to go to the toilet and passing urine before you're having any intimacy. Those would be kind of my top tips. Will, anything to add?
I think the only thing I'd add to that is to, you know, talk to your clinical team about getting a referral for some specialist help, you know, from the urologist, because there may be, you know, anything from simple things like pelvic floor exercises right through to, you know, artificial sphincters and things. There may be, you know, some some help and some investigations they can do that might actually be able to improve things as well as manage them.
Thank you, Will. I'm really glad that we've got a question that's come in for Chris. So Chris, you mentioned some of the success that you'd had using the vacuum pump. So the question that's come in here is, how soon after surgery did you begin use of the penile rehabilitation and use of the vacuum pump?
I basically went with the information I'd received from the forum and from the specialist nurses, and it was about 10 or 11 weeks after the surgery that I gave it a tentative go, basically just for rehabilitation to start with. I did start using it for penetration, and it's quite successful if you've got the right pump and the right rings and everything. But basically, I had it set in my mind just to get using it every other day for 10 minutes, just to hold an erection and not necessarily to use the bands, just to keep everything in working order.
Fantastic. Thank you, Chris. We've had a good question come in here that kind of looks at this a little bit from the partner's perspective, and it says, as men may not be interested in talking about sex if they're overwhelmed with information, or if they're afraid, or if they're nervous about diagnosis, do you think healthcare professionals kind of directly speaking to their partners to kind of empower and engage the partners to drive things from their side, obviously with the appropriate consent from the patient, is that helpful? Is that something you've seen success with? So Sophie or Will?
I mean, I think we often see in clinics, it will be the partner that raises this. Maybe it's easy, when you're not the person who the focus is on. It will often be, that nudge. You asked, you wanted to ask them about that. So yeah, I think it's really important to involve the partners. And if appropriate, I see no reason why you couldn't speak to the partner alone. I think it's actually important to do things in all ways, talk to people when the partner is there and also when the partner isn't there, because there may be some conversations that are easier one way or another. But yeah, I think if there is a partner, then involving them is absolutely crucial.
Thank you, Will. Sophie, anything to add on that kind of clinician partner dynamic?
I don't think so. I think I know that there was just sometimes that, when you're in clinic, partners can feel quite isolated and like you are just talking, especially with follow-ups and things, that you are then just focusing on the man and how the man's feeling and doing, when actually this is, this affects the partner very much so after treatment. And I've certainly spoken to a lot of partners who feel that way, that they're not included in the conversations, because of course it is about the man after the diagnosis and how they're feeling and doing. And so obviously, yeah, they can feel quite isolated and alone after diagnosis. So yeah, always try and have that involvement when you can, and obviously we're there to support partners when and if needed.
Thank you, Sophie. One that quite a few people have asked is around choosing a pump. Now, obviously, we as an organisation can't give any official recommendations or advice around this, but I suppose if I phrase this as, are there any particular pumps that you see men particularly reporting good results from, or that you see as generally the norm that men use, or maybe even kind of types of pump rather than makes and names? What's the kind of the thinking there?
Chris, did you have a specific type of pump that you used?
Yeah, I asked for a pump straight away. I realised that some people can't get a pump on prescription. They're about £280. I asked for one in my area. I was given the Soma Erect Response 2, which is a one-handed pump, which leaves your other hand, if you want to have penetration, to slip the ring down once you're fully erect. I've still got the same pump now. I've only had to change the head unit in 8 years. It's absolutely fantastic. Great piece of kit.
So that's from iMedicare. That is a pump that's used very frequently across the NHS. They often set up pump clinics in different hospitals. So that is one of the pumps that is used, I think, most frequently in the NHS. As I say, it's iMedicare.
That's the one what we use. I mean, I'm sure there are other brands out there, but we have we run a clinic in conjunction with iMedicare. Yeah, I'm sure there are other ones out there, but that's certainly one that's, I think, used in an awful lot of hospitals. That's a good plug for them, isn't it?
Yeah. There is others, and yeah, if people wanted to get in contact, and we normally, if we send out kind of emails, we will send you a few different makes, because there are other ones out there, but I think that is the one that's mainly prescribed on the NHS from your specialist team.
Thank you all. I think we've got time for one last question, and again, this is one that we've had a couple along these lines, and in fact, I'll come back to one of the ones specifically that came in beforehand, which is from somebody who was actually seeking to start a new relationship, or kind of on the market, if you like, for a new relationship post-treatment, and still with kind of quite considerable erectile dysfunction. So we kind of touched on the importance of communication, but not necessarily in this context. So Sophie, Will, anything to say around kind of how you communicate clearly and openly, and how you tell prospective partners when you're in that stage of life?
It's a really good question. You know, sex isn't just for married couples, obviously, and it's really tricky. You may not want to tell this person you've got, you know, sexual problems. You may not want to tell them you've got prostate cancer. So I think the way you approach it would maybe depend on the severity of your sexual dysfunction. So it may be that not saying anything might be an option for you. You know, if maybe you're using a tablet, you know, a Viagra type tablet, it maybe you just want to use that and see what happens. You may want to tell them something, that you have some problems, but not everything. Or you may want to, you know, give sort of full disclosure. And I don't think there's a right answer. But if you do decide you do want to talk about this, then I think probably, you know, planning ahead, pick the right time, pick the right place. You know, don't do it as you're jumping into bed. That may be not going to be the best time. So think about what you're going to say. Maybe think also about the words you're going to use. You know, again, it's an embarrassing subject. You know, what word are you going to use for erection? Are you going to use erection? Are you going to talk about how hard you are, how aroused you are? You know, I know men often use humour, you know, talk about rising to the occasion, but you may not want to use humour. And I think, you know, it's important to, you know, in a calm environment, to explain the cause, you know, reassure them that maybe these problems aren't about them. They may have insecurities. And, you know, let them know that you want to have a sexual relationship, but it may need a bit of time. It may need a different approach. And of course, these things are easy to say, but if you can get to a place where you feel comfortable, then things are going to be a lot easier, because, you know, adrenaline is the enemy of erections. You know, literally a chemical reaction. It will, you know, you will lose your erection. So, you know, if you can, you know, create a calm environment, reduce that anxiety, then it's going to really help. And you can also do things, you know, once you've established more of a relationship, you can think about maybe incorporating some of these sex aids, pumps, you know, whatever you're using, into your sex life, if you feel that's appropriate. So I think it's really difficult, but I think, you know, if you have a think about things ahead of time, then maybe you can find a way that's good for you.
Thank you, Will. We are going to have to wrap up there. It's gone by incredibly quickly, but unfortunately that is all we've got time for this evening. So I wanted to just say a huge thank you to our panel, Sophie, Will, and especially Chris, for sharing his story with such candor and such passion for the benefit of other men in a similar situation. It really is greatly appreciated. So keep an eye on your email inbox over the next few days. We'll be sharing a survey to ask you how you found this webinar. Your thoughts are absolutely vital in helping us to shape our information and support. So please take the time to do this if you can. We also hope to be able to share a recording of this webinar. And please don't forget, there's a wealth of prostate cancer information on our website, and our specialist nurses are available Monday to Friday, 9 to 5 on 0800 074 8383. And I think the just gone into the chat there, you've got our general health information resources and a specific page for our specialist nurse service, which has got some of our other channels like email and live chat and WhatsApp on there as well. So do take a look. But I will wrap up there and say have a good evening, everyone, and take care.